All right, welcome everyone to our mentoring session. My name is Erin, and I'm a palliative care nurse from Canada, working with KEHPCA and Palliative to do a palliative care echo program. We are finishing up our mentoring sessions here, in which we were supporting humanitarian healthcare workers, focusing on palliative care. In May this past year, we started a certificate program that ran for 11 weeks, and we finished that in July. And since then, we've been running mentoring sessions. So there are sessions that we look a bit more at some topics that the participants were wanting to find out some more information about. And this was an introduction session. So introduction to palliative care, especially in low resource settings where there could be a humanitarian crisis. I see we have our team from South Sudan on the call. It's great to see you. Some of you might be calling in and joining the call today to learn more about working in this setting, or you're currently working in a humanitarian setting and you want to learn more about palliative care. So in either situation, that's fine. We love to connect. Hopefully in 2023, we will be able to run another certificate course, and that will again be in combination with our Kenya Hospice and Palliative Care Association here in Kenya. I live here in Nairobi, and in combination with Palliative, which is a global network of palliative care providers, as well as humanitarian workers that are trying to promote palliative care in their setting. So today we have a topic that we have talked about earlier in the certificate course, but we will continue to learn and discuss and have a case study in which we will talk about pediatric palliative care. So in your settings, you may see adults and children, or you may just see children, but we will be talking about how to provide palliative care in a humanitarian setting for children with a life-limiting or life-threatening illness. And we're really honored to have Professor Julia Downing with us today. She is the lead executive director of ICPCN, which is the International Children's Network for Palliative Care. International
International Children's Palliative Care Network. Too many acronyms.
I had all the words, but not in the right order. Sorry about that, Julia. But it's great that she's here with us. She's a very strong supporter of people working in difficult settings when they have to try to incorporate palliative care into their work. And I am really excited to hear what she has to say. For some of you who come through the certificate, it may be some of the information will be repeated, but some of you I can see here are new to the ECHO program, so that's okay. That today it might be new information for you. The way that ECHO works, and I'll just introduce or hand it over to Julia in just a minute, but the way ECHO works is we are set up as a hub, and we're people that are trying to, as facilitators or as teachers, trying to impart information to people that are working in the field or different areas where it could be difficult to access education or training. So with the certificate program, we meet regularly and we do a lecture, which is about 20 minutes. We allow for a lot of time of question and answer directly to the person who's leading the session. And then we move into a case discussion. So we have a real life patient or an example of a real life patient where we talk about it. And then we engage again in a time of discussion. Often 100% of the time, pretty much, the case is related to the topic that we're learning so that we can be well-rounded in the information that we're going to be taking back to the field as you go and work. And again, if you are not working in a field in humanitarian settings, please do pass this information on to someone you're working with, or share your contact details with us, and we'll try to stay connected because we will be offering a new program coming up soon. But with that, I will pass over the details to the microphone to Julia, and we will move on with our session. Thanks for being here today, and just a reminder for the etiquette on Zoom, just to leave yourself on mute, but please do use the chat. We'll be monitoring that. Thank you.
Thank you, Erin, and it's good to see everybody again, and I hope you can hear me okay. and hopefully you can see my slides. So as Erin said, I'm the Chief Executive of the International Children's Palliative Care Network. I'm also a professor at Makerere University in Uganda, and I've been working in East Africa for over 20 years and globally for about 15 years. So hopefully I can share some of my experience, and also I've got experience in working in humanitarian settings. We've been doing some work recently in Iraq, I've been training in Gaza, in northern Uganda, in some of the refugee settlements. I've done some work with Megan and Erin and Palliative in other settings. So today we're going to look at children's palliative care in humanitarian settings. And as Erin said, we want to have some discussion. So I'm going to talk for about 20 minutes. And so it's just really highlighting some of the key points in those 20 minutes, and then we'll be able to have some discussion, and Erin will lead us in a case presentation. So I always like to start by reminding ourselves that we are trying to improve the care of children like these two, wherever they live. Whether they live in a setting where there is humanitarian crisis, or whether they live in capital city where it's relatively stable, whether they live in a high income or a low income country. What we're trying to do is make sure that children like these two who need palliative care can have access to such care. So we utilize the World Health Organization definition of palliative care for children. I like this because it has some key issues that we will talk about in a minute, but it's about active total care of the child's body, mind and spirit. It's about caring for the child and the family. It's about providing care when illness is diagnosed. And in fact, in many humanitarian settings, the child might not actually have a diagnosis. They might not be able to afford to have a biopsy, or they might present with such advanced disease that really it doesn't matter what the diagnosis is. The key thing is to make them comfortable. And importantly, palliative care continues regardless of whether or not a child is receiving treatment aimed at the disease. We also talk about the multidisciplinary approach. We talk about involving the family and the community, but importantly, we can provide palliative care for children across all settings, and even if resources are limited. So wherever the child is, that's where we're trying to provide care. So a quick kind of highlights from palliative care. It's about providing relief from pain and other distressing symptoms. It's about affirming life and enhancing quality of life. People often say to me, oh, isn't it depressing working with dying children? Well, no, because actually palliative care is about life. It's about enabling them to live as well as possible within the context of their family for the life that they have lived. So we're supporting the family, we're supporting the child. We're working together as a team. Now, in many situations, that team might just be a doctor and a nurse, or a nurse and a clinical officer, or a nurse and an emergency aid worker. Whoever is involved, we try and work as a team. Now, in an ideal setting, you'll have a wide team that includes teachers, religious leaders, counsellors, social workers, etc., etc. But the reality is, particularly in humanitarian settings, that we work with the limited team that we have. And as is so important in terms of humanitarian settings, wherever that child is that needs the care, whether that be in a refugee settlement, whether that be in a temporary internally displacement camp, whatever it might be, that is where we provide that care. So important, and I think this is where sometimes there's some misunderstandings. It's not just about the last few days or weeks of life. People think it's about end of life care, but it's broader than that. We're looking at the whole spectrum of their condition. We've talked about quality of life, the holistic nature, the physical, the psychological, spiritual, social, cultural. Another misconception is that palliative care is just for children with cancer. but it's not. It's for children with cancer and other diagnoses. And I think our case study is going to be looking at a child born prematurely. It requires active care, and where possible, it's about a multidisciplinary team. But also, I think it's important to remind ourselves, when is the best time to begin begin palliative care for a child with a life-threatening disease? As soon as we can, as soon as that child comes to us and is asking or is needing care. So when is it appropriate to start pediatric palliative care? Well, the American Academy of Pediatrics say it should be offered at diagnosis and continued throughout the course of illness. That goes alongside the World Health Organization definition. And if you look at other definitions, such as Together for Short Lives in the UK, if you look at the handbook from the WHO for pediatrics, but also for humanitarian settings, it's from diagnosis, or as I said earlier, before diagnosis, throughout the course of the illness. And this is quite a helpful model that helps us to see that palliative care goes alongside care aimed at cure, aimed at managing the disease. So some other myths about pediatric palliative care. We should not say nothing more can be done. There is always something that can be done. And if we say, oh, sorry, there's nothing more that can be done, parents feel we're giving up. We feel that we have failed. And there is also something that can be done. Another myth is that it's only available when no disease-directed care is possible. And as we saw in that previous model, it goes alongside care aimed at disease. People think, oh, if you provide palliative care, it will bring the child's death sooner. That is not the case. And from some studies looking at pediatric, but also adult palliative care, actually, if you improve quality of life, then they can actually live longer. Some people think that care must be given at home, or care must be given in the hospital. And as we've already said, it can be provided wherever that child is. And there's also a misconception that you can't provide palliative care in humanitarian settings. And we need to change that. And this course and the work of PalChase, ICPCN and others is trying to bring about that change. So who needs palliative care? Well, as I said, people often think it's for children with cancer. But if you look at this graph, which is from the Global Atlas of Palliative Care, you can see that over 30% of children who need palliative care have been born prematurely, they have trauma at birth, or they have congenital malformations. Nearly 30% have HIV disease, and certainly within the East African context, that's a significant number. And it's only a small number that have cancer. And so we need to think broadly about the type of children who need palliative care. Together for Short Lives in the UK identified these 4 different groups of children that need palliative care. So those that have a life-threatening condition for which curative treatment may be feasible but can fail, such as cancer. Some conditions where premature death is inevitable. Some progressive conditions without curative treatment options. And some irreversible but non-progressive conditions that might cause severe disability, leading to susceptibility to health complications and likelihood of premature death. For example, children with complex disabilities might be more prone to getting chest infections and pneumonia and premature death from that. So different groups of children that need palliative care. And I'd just like to pose a question. What about in humanitarian settings? Now, I've borrowed this case from Megan, and the photo is not related to the case for confidentiality reasons. But this was a case that Megan has talked about, a young child who had bilateral club feet, living in a refugee settlement. He was referred to palliative care because he was seen as being disabled. He was seen as not being able to do things. He wouldn't live long, but he only had club feet. When I say he only had club feet, what I mean is that they were able to get treatment for him. Mother was alone with 3 children, but the community health workers in palliative care were able to support them to get an orthopedic program, to get surgery done, to support travel to appointments and childcare, etc., etc. So not your typical palliative care case, but sometimes in humanitarian settings and in low resource settings where there aren't perhaps other services available, we find children with complex needs, children with pain will be referred to the palliative care program. So another key thing that we talk about in palliative care is hoping for the best, but planning for the worst. And this is where the 2 things can go hand in hand. If you have a child who has cancer, we'll be hoping for the best and we'll be providing chemotherapy. But at the same time, we'll be aware that maybe they have advanced disease and we don't think this chemotherapy is going to cure them. So also planning for that situation. It's often called parallel planning, and in perinatal and neonatal palliative care, that is key. And we might hear a bit about that in the case that we're going to hear from in a minute. So I'm just going to run very quickly through, and we're not going to go into a lot of detail on all of these, but some of the principles of palliative care in children that we can then apply within the humanitarian setting. So we've already said across the continuum of care, from diagnosis through to death and into bereavement, across the variety of care settings, wherever the child is. And I think this is a challenge within humanitarian settings, because sometimes families might be passing through, maybe they're in a refugee settlement and they might be passing through, they'll be there for maybe 6 months. Maybe they've come with their sick child and they don't have access to their medical records because they've fled their home situation. Maybe we can't provide that ongoing care because we don't know where they're going next, but we can provide the care that we can within the context where we're working. So across the continuum of care and in the place of care, whether that be in a hut, whether that be in a home, whether it be in a tent, wherever they are, we try and provide that care. Pain and symptom management are key. Now, they're not the only things, and often people think about palliative care, it's about pain. It's not just about pain, but pain is a key symptom. So managing pain and symptoms. And again, that can be a challenge for us within the humanitarian setting, because maybe we don't have access to the medicines. Maybe we have access to medicines, but they're in adult formulations. How do we provide that for the child? How do we make sure that the child and the family have access to pain and symptom management? What about if the child needs oxygen? And remembering that it's not just about medication, but non-pharmacological management of pain as well, and other symptoms. And the challenge is, if we're in a humanitarian setting, their pain is likely to be not just physical, but psychological, social, and spiritual as well. So a challenge for us, but a key component of the work that we do. Emotional support is like paramount. So in the definitions, we talk about physical, psychological, social, and spiritual. So emotional support. And in many humanitarian settings, the emotional support needed because they have a child who is dying, alongside the emotional support for the fact that they've had to maybe flee their country, or they don't know where the rest of their family members are. They don't know if they're dead or alive. The fact that I was listening to an interview with a mother in Somalia, where there is horrendous famine. And, the challenges for her, I think it was her 3rd child who had died from malnutrition because they couldn't get food. How do we provide care in that situation? So this is really important for both the child and the family. And I think one of the key things for us is that we need to be open and honest in our communication. We need to say what we can provide. We need to be honest. If a parent asks us, is my child dying? We need to address that question, and we need to be honest and open. And one of the key things in pediatric palliative care is never lie to a child, because they will know that and you will soon lose trust. But building that trusting relationship in a humanitarian setting can be challenging, particularly if it's an acute humanitarian setting. And then, of course, we have all the social issues. And how do that play out within the humanitarian context? They might be living in a refugee settlement. They might have lost support of all their friends. There might be stigma. Not only are they now refugees, but they have the stigma of having a child with a life-limiting condition or with a chronic complex disability. How does that work in terms of schooling? So important. Some of the work that we've done in talking to children and young people in Uganda and Kenya and places is the importance that they place on being able to attend school. Spiritual issues, key, again, linking in with this social, psychological, spiritual, cultural issues, trying to think about hope. And I think one of the key things within children's palliative care is that often hope changes. So from hoping for a cure, parents might then hope that their child will be alive for the next birthday or for the birth of their next child. So the hope changes, but so key within the context of palliative care. And whilst I said very early on that palliative care is not just about end of life care, obviously end of life care is an important part of children's palliative care. And how do we provide that? And what are the challenges within the humanitarian setting? And that ongoing grief and bereavement care, many of the families that we're working with in humanitarian settings will be carrying grief, a whole lot of grief. And how do we support them in that and support them in terms of grief and bereavement for their sick child? We've already briefly talked about communication, so key, and how do we utilize tools that exist to help us in terms of communication? Working with the families, and of course in humanitarian settings, maybe they haven't got the whole family there. And in cultures where the extended family is important and it's the extended family who make decisions, how does that impact the care that we give? Financial issues, always key, but even more so within a humanitarian setting. How do we make sure that they can receive the care that they need for their child? And any costs can be supported, and how do we prevent them going even further into poverty than they already are? And teamwork, I've mentioned teamwork already, so key that we work well together, not just as palliative care people, but work well with MSF, with the other emergency aid groups, with the governments, with the local teams, with teachers, with relief organizations, working well together to provide such care. So in integrating palliative care within humanitarian settings, within fragile, vulnerable, conflict settings, how do we do that? And there's been quite a bit of work over the last few years in doing that. And these are some of the guides that can be found online. Most of them can be downloaded free. So there's a field manual for palliative care in humanitarian crisis. There's the WHO book on integrating palliative care into humanitarian emergencies and crises. And there's a similar one for pediatric palliative care. The Sphere Handbook, palliative care is now in the Sphere Handbook, and that is a key development, an important development. And then the WHO supported indicators for palliative care, but it includes this conceptual module, and it helps us to think about the different components needed in integrating palliative care. Also, in the recent revised global standards for pediatric palliative care, the GOPACs, there are standards for pediatric palliative care in humanitarian emergencies and humanitarian settings. And this is a key development and an important development. But we know there are many challenges, and my time is nearly up, so I'll just talk briefly about some of these. But this lack of recognition of the need for children's palliative care, or the fact that we can provide it in humanitarian settings. Lack of policies, lack of access to education, treatment, trained professionals, lack of resources, challenges in end-of-life care and decision-making. The fact that often we have a mobile population, there is a lack of records. And in many humanitarian settings, palliative care is not the priority. We're working with a traumatized population where there are fear and other emotional issues, and providing ongoing support is complex. We also know the challenge of access to medicines, and there's been a lot of work with MSF and within the humanitarian setting to increase access to opioids and other medications. But we need to try and understand the illness from the child and family's perspective. We need to give them the information they need. We need to have appropriate discussions with families around the goals of care, around what we're aiming for. And importantly, we can develop the roles and skills of workers, of healthcare workers in humanitarian settings to provide pediatric palliative care, so that children and their families get the best possible quality of life in order to relieve their suffering, to provide care with competence and compassion, and to respectfully accompany the child and family on their journey, so that all children, wherever they live, and particularly in humanitarian settings, which is our focus, can have access to palliative care. So that's a very quick run through around some of the principles of children's palliative care and trying to apply that within a humanitarian setting. Thank you.
Thank you so much, Julia, for taking the time to spend with us today. Are there any questions from the group? Or if you have, as you can tell, Professor Julia has worked in the field and has been working within the palliative care community for many years. So even if you have a particular question about even a case or an example that was challenging, we have about 10 or 15 minutes now for a short time of discussion, and then we'll move to the case. So we're kind of a small group, so you could unmute if you have a question, particularly about maybe even a challenge that you face.
Yes. Yes.
Karibu. Yes.
Hello. Yes, this is Bangbul from South Sudan, MSF OCA.
Yes.
I have a question about the age group in a palliative care. So it's a bit confusion for us here now, like a neonate. So are we going to start it from which age group? For example, like there is some neonate which was born with abnormality. So maybe 2 days or maybe after 1 week. Are they palliative care, or they can be premature, like for some children which was born, maybe they have only some weeks whereby they did not complete 9 months. So can you tell us the really exactly age group where we can start the palliative care? So that one now is give us a little bit confusion from there.
Okay, so yes, so any child should have access to palliative care, and neonatal and perinatal palliative care is certainly a developing field, and there's a lot of work going on in terms of the provision of neonatal palliative care. So let me just give you a quick example. Hang on, let me just share my screen. Okay, so neonates and in some settings, people will know before their baby is born that their baby maybe has a life-limiting condition. In other settings, they won't know until they are born. And often in the humanitarian setting, it's likely to be that. And key is that we look at how we can provide palliative care in those settings. So with a newborn baby who is very sick and is likely to be dying, but also if we know that the child is sick before they're born, we need to plan for pregnancy, plan for their birth, plan for what life they will have, and also plan for their death. And this is very much where we think about hoping for the best but planning for the worst. And so hoping that that child will live, but planning for the fact that they might not. And so there's a lot of work being done in terms of neonatal palliative care, in terms of working with families to say, okay, what do you want when your baby's born? Do you want to take your baby home? Do you want the baby to be cared for in hospital? And in many humanitarian settings, the facilities available in the hospital might well be limited. So yes, we provide palliative care from as soon as that child is born, and even before they're born, if we know that there's going to be a challenge, so that we can support the families through this difficult time. So in looking at antenatal palliative care, we look at neonatal palliative care, we look at the antenatal, we look at the birth and potential death, and we look at the continuing care, and we try and help support the families through that challenging and difficult time of what is happening with their baby. And just I'll finish there, but just to say that some of the work that has been done with mothers is that they want to know what's happening, and they want us to talk to them about it. They want us to talk about palliative care and how we can support them and through this challenging time. So yes, neonates key, right through the spectrum, so all ages. Yeah, I hope that helped.
Sorry, I have also another question, an additional questions. I'm called Simon Chaltich. I'm from MSWCA. I'm MD. So my question is about the neonate, the one whom one of the colleagues asked. We have a little bit challenge on neonate. So we don't know the cut edge for the neonate that we can put on palliatives. And what basis are we going to consider a neonate to be palliatives? Because we have some neonates who are less than 1 month, who are less than 1 kg, and they are less than 28 weeks. So those neonates, I don't know which criteria are we going to use to consider these neonates are palliatives, and this one are supposed to be at least monitored with other neonates. So it's really very difficult. In the guideline, neonatal guideline in MSF, we have that a neonate less than 1 month are supposed to be palliatives. But it's really difficult from other institutions. Other people say no. Neonate less than one month less than 1 kg cannot be palliatives. So it's very contagious. We don't know which is which. So I want to know this really exactly which is the cut edge of the neonates that we consider as palliatives. Thank you very much.
It's really hard. I can't give you a cut because it's different. So you could have a neonate who is like 1 kg who, for whatever reasons, with good care, good support, will survive, and then you will have one that will die. So this is where you have to be providing care alongside each other. So making sure that neonate is that any pain is managed, any symptoms are managed, etc. But if there's still things that can be done to work towards ensuring that the baby will live, then you do those as well. So it is working hand in hand. But it's say if you think that child has a condition, whether it's a congenital abnormality, whether it's just because they're very, very low birth weight. And I think Erin's going to be discussing a case in a minute that is very low birth weight. If you think that there is some reason why that baby has a life-limiting condition, then we should be looking at providing palliative care for them. But this is where it's really important to remember that palliative, it's not either curative care or palliative care. The two can go hand in hand, because we're hoping for the best, but we're also preparing for the worst. I don't know if that helps, and I don't perhaps have enough understanding of the MSF guidelines. Erin, you might have a bit more of a understanding of the specific guidelines.
I mean, the one thing I think with these really challenging cases where, of course, I think every culture would prefer not to think about the death of a child when they've just been born, right? So I think we all can acknowledge that it's not easy, especially when we think of palliative care, like Professor Julia is saying, where it's an either or. But I think if we can help our colleagues understand that we can try to continue with curative treatment, depending on, again, the case. Every case is going to be different. And possibly if we refer to palliative care and the palliative care team joins us and the child does well, we discharge from palliative care. It's not to say that as soon as the child comes on palliative care and, you know, begins to improve based on the treatment protocol or whatever the suggestion was, that you can, you know, or you just reduce your visits for palliative care. It's not to say that as soon as they're palliative and if the child does start to improve, you don't engage with the medical team again. I think it's a little bit different when people go home, but I think most of the cases that you're talking about, these neonates, most likely would be dying at the hospital. So in those situations, I think keeping the conversation open between the medical team and palliative care team, I'm sure it's very difficult in your situation where the medical team is very overrun. So they may quickly or try to find ways to share the weight of some of these very difficult cases. So they pass it along to the palliative care team, and then they maybe move on to another admission or something like that. But I think it's important, you know, the medical team can also provide a palliative care approach. They might not know all the details about the specific drugs that you guys are beginning to learn more. But yeah, I think in general, what we want to be teaching and what we want you to be learning is that some of these concepts, how to talk to families about difficult news, that's something that we all should be doing. How to, engage to identify spiritual concerns that families might have around this. All those kinds of things, you know, the particulars about specific drugs, or how do you withhold, for example, IV treatment or special ICU care, especially when the child is quite little. I mean, those kind of things are very particular and very hard to make those decisions. But I think actually today's questions have led really good into our case discussion. So I do hope that you guys can stay on for the next half an hour or so, because the case that I have to share is very, very on par with this topic. And so maybe unless
there's another question. No, there's another comment or question from Ibrahim about circumstances where once you decide to initiate providing palliative care, the parent becomes resistant and decides that you should leave the child die. How should you approach that, especially in specific cultures? And I think he's referring to a situation, and I think that's one of our challenges, and it's about how we talk about palliative care. So palliative care isn't giving up. And I think that's really important. So it's about how we frame palliative care, but also we have to work within some of these, the context in which they're in. You know, this lady that I was hearing interviewed in Somalia, you know, this was her third child who had died from malnutrition. And it's like, again, what kind of, once she knew this child was going to die, she almost gave up on that child. And that was partly because of what she'd already been through. It was partly because of that emotional burden. It was partly because she didn't feel she had the support that she needed. So there isn't easy answers to this, but I think it's about trying to understand a bit the culture that we're working in, trying to understand, particularly in humanitarian settings, where we're coming from. I know in a couple of places I've worked where if you talk about somebody's death, you're bringing it on them. So by saying that you think the child is going to die, you're almost making that child die. And so how do we fit that within, how do we fit palliative care within that culture? And really supporting supporting that family. And if they've come through a really difficult humanitarian crisis setting, if it's their third, fourth, fifth child who's dying, you can kind of understand where they're coming from. So it's about trying to provide that care within and support the family. And I think that's a key thing, actually, just to say, Erin, before is that whilst we're caring for the child, we're also caring for the family and caring for the parents. And sometimes towards the end of life, you're almost caring more for the parents and the family as you're supporting them through what is happening to their child.
Yeah, and I think,
yeah, carry on.
I think some of these discussions are just the initial discussions. I would love, Dr. Simon and Bang Bol, that you would feel that this is the beginning of a strong relationship within children's palliative care. So, because I believe, I haven't worked in a humanitarian setting before, but I believe that the weight and the heaviness is real for providers. So we don't, although I can't come and be with you physically, I do think a huge part of our ECHO program is that we meet regularly, we interact through WhatsApp and chatting, you have access to our emails. If there are cases that you actually, the outcome isn't necessarily going to change, but you would like to talk to someone beyond even just your MSF colleague, just to run some ideas past. What are some other things you can do? I mean, I think there's quite a few of us that would be willing to engage with you like that on some of these situations that I don't think any one person should feel the weight of making those kinds of decisions. Again, we may not know the particulars of your situation or the protocols or even the family's particular situation, but I think a huge part of growing this program in East Africa is that we stand alongside you and we go through it together. Yeah.
And we are also doing some bits of work with MSF, and I know there's different MSFs, but that's also, so it's also helpful for us to hear from people in the field, and so we can input into those discussions.
Yeah, let's go into the case now, because I think you guys will find this one quite interesting.
Erin, I think can I just say goodbye? I'm gonna have to go.
Yeah, thanks for being here, Julia.
Sorry, I can't stay for the rest, but good to see you all, and great discussions. So thank you.
And if you guys need to get in touch with Julia, we can share, or Julia, what's the best way for people to stay connected?
Yeah, you could either share my email, or if you go to the ICPCN website, www.icpcn.org, you can find some email addresses to contact us.
Nice. Thanks again for being here.
Good to see you all.
Thank you, Julia. Thank you very much.
So let's go into our case presentation. So a big part of the way we do ECHO is we try to link our topic to an actual patient and a situation. So I want to introduce you to a patient that we met in Bangladesh, actually, with MSF. So in Bangladesh, they have an MSF hospital called Goya Lamara Hospital, in which one of our colleagues, Rachel, was a former nurse manager. So she gave us permission to share this case, and it's quite in line with what we've been talking about today. So as we go through the case, I want you to remember these questions. So how could or should we adapt our hospital guidelines to the local context? How could we have better supported collaborative decision-making within our healthcare team? How could we better involve the family in developing a plan of care? And how could we have supported members of the team who had different opinions about this case? So this is a case I'll introduce you to. It's a boy, a male, who was at 1 day old when we met the patient. They were extremely low birth weight and extreme prematurity. At that point, they didn't have any other diagnoses. So when the child was admitted to the hospital, they were born at 790 grams, which is extremely low birth weight and premature. from the Rohingya community. So in Bangladesh, the Rohingya were the refugees that came over to Bangladesh, and they were referred to the tertiary level hospital in the refugee camp, where they did have access to NICU care. An IV was in place when the patient was admitted, and they were receiving maintenance IV fluids at that time. The child's vital signs were normal, or the neonate's vital signs were normal. The oxygen saturations were over 90 without oxygen and was showing minimal respiratory distress. The neonate was pink, active, and good tone, considering the gestational age and being very premature. So in terms of the hospital in Bangladesh, where we were working, the palliative care guidelines were as follows. If high-level NICU is unavailable for neonates under 1,000 grams, it is recommended to avoid measures that may extend the dying phase of the patient and prolong suffering, such as IV fluids and oxygen. So a decision was made to continue in this situation, the IV, due to strong opinions amongst the team and the fact that the IV was actually already in place when the child was admitted. So the child was born somewhere else and they were admitted to the unit after that. We had continuous pulse oximetry monitoring the oxygen level, but no antibiotics, no oxygen, and no caffeine was given, and there was do not attempt resuscitation for the child. On day 3, an NG tube was inserted and trophic feed started, 1 to 2 mils every hour and slowly increased. The IV cannula for this patient stopped working on day 3, and it was removed and was not reinserted. And the neonate died, unfortunately, on day 10 of life. So in terms of pain and symptoms, the patient showed no symptoms of pain. They had, again, minimal respiratory distress and no significant signs of hunger or interest in feeding, but occasional drops of breast milk were given orally. The temperature regulation for this child required frequent support for episodes of hypothermia. There was some confusion about the daily weights, and there was significant weight loss noted, which was causing a lot of distress for the nurses on the team. We supported the mother to do skin-to-skin care, especially in the last few days of the child's life. Psychosocial and family concerns. So the mother and the father were at the bedside, and they were aware of the child's prognosis, according to the team. Both parents had been quite involved in the care, and they were very affectionate with the baby. The 2-year-old sister came to the hospital to spend some time together as a family. And the mother expressed concerns that the baby was not feeding, and the baby also was not urinating at that time. The spiritual concerns for the family were that they asked the imam to come and give an adhan, which was very important to them, and the family chose to give the baby a name on day 2 of life. So that was really important. In terms of communication, the team believed that the parents understood the baby's prognosis. There was a lack of clarity about the family's wishes, and there was some confusion related to kangaroo mother care, which is the skin-to-skin care that was recommended for this case. So as we think about the team, it sounds like this is kind of similar to what the team in South Sudan is dealing with. I want us to look actually to our healthcare workers. So we're going to switch focus a little bit and now begin to think of the perception of this case. So one of the clinicians, the doctor, gave a few comments, and I wanted to share them. But regarding prematures, it's very easy because you have a protocol that we didn't decide. A lot of studies and more intelligent people than us decide it on a regular scientific basis. Now look, in this context, under 1 kg is not compatible with life. In our context, we don't have a proper ICU, and we don't have surfactant for the lungs. We don't have tubes to intubate. We don't have a lot of things. And they continued, sometimes doing more is doing worse. We need to accept that as health providers, we, The first thing we always need to remember is to not harm, do not harm. And by giving treatments many, many times, we are harming. So we need to step back a little and think about which treatments are we giving, why, what is our goal, and what are the side effects. And the last comment, the four of them, the parents and siblings, stayed all the time together until the baby passed away. It was very peaceful and it was very nice. And I think the experience for this family was able to have this time with the baby and be surrounded by healthcare. It was very nice for them. I think that was very good for the staff to feel they did something good. And as we look to the perception of another clinician on the team, this clinician said the family can complain that we are not giving any feeding to the baby. How will the baby survive without feeding? So what is the treatment? The next thought, if we decide that this on the first day, I think it's not acceptable to me. For example, he felt that we shouldn't do a trial of treatment, including IV fluids, feeding, antibiotics, and oxygen. The second clinician continued. I'll just remind people to stay on mute until we have the group discussion time. The second doctor continued, even I saw 600, 700 babies survive in our hospital. So this encourages me to refer the patient, maybe, I don't know, the baby survives or not later. I do not know, but when we, as a doctor, if I can treat a patient, we see that the baby is dying and we are not doing anything, that makes me feel some bad feelings. But what I am telling is that we can consider some opinion of the patient's family. If the patient's family wants, I think we should give them priority also. That is the main thing. A protocol may have after huge experience and huge research. So that protocol is good. I also agree. But during applying the protocol, we should consider the place of the patient and mainly the culture. So as we think about areas that we can learn in this situation, with more experience, the team did observe actually that nearly all neonates between 1 to 1.25 kg did not survive, even with all of their efforts. As they reflected, they also identified the increasing acceptance of focusing on palliative care for neonates under 1 kg. They began to understand the importance of not starting resuscitation or oxygen IV fluids from the beginning because they don't change the outcome and are often very challenging to stop. And we also learned the importance of open discussion amongst our team. Especially when we tried to encourage other people and we were supporting others to express any concerns they had about the case. In terms of ongoing challenges, we do want to identify how to involve the family better in these decision-making situations when life-prolonging care is not recommended. And sometimes there's lack of familiarity with medical treatment and this can be due to limited education. So in summary, this patient was a 790-gram, extremely low birth weight premature infant. Minimal supportive care was offered and the neonate died at day 10 of life. There was quite a few different perceptions amongst the team about the care plan and the decisions that were made, which we also just saw from our discussion in question time earlier, of particularly at what age or what weight or when would you consider someone for palliative care. So as we move into the time of questions for this case for the next 10 or 15 minutes, I want us to think about these questions. I'll put them in the chat so we can kind of be looking at one another during this time. But how could or should we adapt our guidelines so that they can be related to the local context? How could we have better supported a collaborative decision making within the team? And how do we better involve families as we develop the plan of care? And what do you do when you have other team members who might have different opinions about the case? What do you do then? So we'll just open the question time up for discussion. I'll put those questions in the chat. But I'm really interested to hear, even from the team at MSF, what your thoughts are on this case. And if you have any particular comment related to the question. but anyone is able to share. Just raise your hand or unmute. So what do we do in these kinds of situations? I think earlier when we were talking with Julia, I think we all agree that these are not easy decisions to be making. Dr. Simon, are you still with us? What are your thoughts after this case from Bangladesh?
Yes,
Or
we are
Bangladesh?
still with you. We are still there. Yeah. We are
What
still there.
what are your thoughts? Do you guys also have a similar protocol to not initiate IV or oxygen therapy for patients under 1 kg?
Yeah, of course, we have oxygen therapy. Hello?
Yeah,
Yes, we have oxygen therapy.
So
And
in-
also we also have United guidelines. But that's why we have confusion. That is the reason why we ask you, so that we need to be in one chapter.
yeah. Are your guidelines the same where you wouldn't initiate treatment for children that are that little?
Yeah, our guideline is the same.
It's the same. Okay. And has your
Yes.
team been facing some different opinions on that?
Of course, they are not yet having opinion, because the palliative program is a new in the
Yeah.
project, so whereby we are not yet catch up the really full implementation of it.
Yeah.
So it seems like as the training that had happened in last 3 months is the past
Yeah.
training us with MS service staff. So whereby
Yeah.
now everything is new from us. So
Yeah.
we are a bit running. So
Yeah.
yeah.
Right. Yeah, sometimes I'm sure
Yeah.
it can be
Yeah, the program is new. Yeah.
it can be a bit challenging when it's
Let
new
me add
information.
something,
But yes,
Erin.
go ahead. Yeah, Simon.
Yeah, what I want to add, as Bang put it, the matter is the program is new,
Yeah.
and we have some units who are less than, at least some of them are 0.5 kg.
Yeah.
That is 500 milligram.
Yeah.
Yeah, 500 gram.
Yeah.
So in those units, we don't know what we can, because in the guideline it said less than 1 kg
Yeah.
is more likely palliative. Yeah.
Yeah.
And some units, they have very good vital signs. We have one unit with 700 gram, and
Yeah.
that unit was having very good vital signs. So we continue with the support, and that one is now okay. Yeah, he's alive now. He grows slowly. We put on caffeines until reach 15 kg. Sorry, 1.5 years. That is 1.5 kg. Yeah.
Yeah.
So when that one reach 1.5 kg, then we plan and discharge. So we have those kind of units, and really, as you put it, the decision can be made based on the individualized patients according to the condition of the patient. If you see unit is one of the best, is having good vital signs, progressing well, okay, you can continue. Then this one can survive. And if you see the unit is deteriorating, okay, then you consider for palliative. Yeah.
Yeah.
Yeah. But
So-
if you want to relate this with the clinical work with the guideline and your comments, you as a person working in palliative, you want to
Yeah.
connect all this, then you will be in one chapter. That's why we are asking you these questions.
Yeah.
Yeah.
So these children that are 500 grams, are they premature as well, or were they full term, but just low birth weight?
The one with 1.5 kg or
Yeah.
1,500 gram
Gram?
is
Yeah.
low birth weight.
Yeah.
Because in a premature unit, we have premature and we have moderate premature, very
Yeah.
premature, and extremely premature.
Yeah.
The extremely one, the one who is less than 1 kg. The one
Yeah.
who is 1.5 kg,
Yeah.
that is very low birth weight. It's very low birth weight,
Yeah.
according to the MSF neonatal care guideline.
Right.
It's very
Right.
low birth weight. Yeah.
Yeah.
And those one, yeah, if that unit is 1.5
Mm-hmm.
and above, they don't have problem. Even some of them, they have sucking reflex, they have a swallowing reflex. So we just put them on trophic fed for just 2 days, the first day, the second day, with maintenance fluid. They survive. We don't have problem with that. So the big concern is the unit of less than 1 kg. This is where there's a lot of problem. That's why we really want to know which criteria we can use for palliatives. If you have a unit of less than 1 kg, can we consider, or what are we going to do? Yeah, that's why we have that question.
Yeah,
And the unit are
I'll
different.
just
Some of them
I'll just comment, and then I know Marie has her hand up. So I think the reason that MSF has, and as well with the team in Bangladesh, is they are following the protocols. And I would really challenge you, Simon, and Bengal and the team there, is to begin to keep track of the number of patients. As a team, they all decided that those children that were extremely low birth weight, under 1 kg, even though there were times that they provided IV fluids, they didn't have access to NICU treatment. I'm not sure what your situation in South Sudan is, but because they didn't have access to that intensive care treatment, they decided as a group, after they kind of monitored their unit for some time, that actually, even when they did introduce these treatments of IV and oxygen, the children, in this case, the child died at day 10. So I think it's not an easy, again, like Julia was saying, it's not an easy cut and dry thing, but they began to realize that providing supportive care to these children allowed even the idea of this kangaroo care, right? Oftentimes, if you have a child who is in whatever the highest level of care you have access to, the families can't really engage with the child. I'm sure that a 2-year-old would not be allowed to be in your high dependency unit to spend time with the child. And if the result is the same, that the child will not, make it to month 1 or make it to year 1, allowing the family to have time with them through palliative care approaches is what this team began to see. But it wasn't easy.
Yes, hello.
Yeah.
Yeah, there's something I just want to clarify a bit. Regarding about premature, but there's some premature children which need only kangaroo mother. So if they have no abnormality, so those children, it does not mean that if they have a if they were born a low birth weight, it does not mean that they are palliative. If they have no abnormality, they will be cared as. We can just advise the mothers to keep the child in a warm, like using kangaroo mother. So the problem it is with those who have been abnormality while they have less than 2 kg. So that's where we have a problem. As we narrated out today, I think will be a bit easy because we discuss it as it is.
So at MSF in South Sudan, when a child is possibly considered palliative, does the medical team stop taking responsibility for the care? Does the palliative care team take on full responsibility?
Yeah, of course. Yeah, we have palliative care teams that always take responsibility. If you consider palliatives, so we do something symptom control in that particular department. Like when there's pain, we give morphine. So only symptom control we can do if we consider palliatives. And that's why we are asking you with those questions. The team is there in the hospital. We have nurses and COs, MDs who are in that team. That's why we really want to know which cut age or which cut weight that we can consider as palliatives. As you
Yeah.
told me, like if neonate is less than 1 kg, if we cannot give the treatment, we cannot give oxygen, we cannot do what. So these things is we want to make it clear so that we know it
Yeah.
from the palliative care training, so that we
Yeah.
implement it. The guideline said then if neonate is less than 1 kg,
Yeah.
is considered to be palliatives. Very
Yeah.
clear in the guideline. Yeah.
Right.
But we want to connect it with the training so that we take one action. Are we going
Yeah, I
to
would
stop
say.
everything when the child is less than 1 kg, or what are we going to do?
Yeah. I would say it's an ongoing discussion. So let's keep in touch. I'll let Marie Claire ask her question now, but I think the team at MSF, let's keep talking. This is not the end. Yeah.
Okay,
Yeah,
Uh,
thank
Marie?
you. Welcome.
Yes, I just want to ask a question. The case you presented, the families seemed very consented, very peaceful with the situation. Is it
Yeah.
usually this way, or because I know here in our culture, people, they insist and they want and they don't accept all this. Is it because they don't have the ICU, or because the family was very maybe religious that she accepted? Because it was
Right.
very easy for, I mean, not easy, but they they didn't fight for more, trying to do more. So I don't
Yeah.
know if it is the culture or it is because they were, this is a question that turned around my heart.
Yeah. Yeah, I think it's really important to take that into consideration. I think if this family was very resistant to a palliative
Yes.
care approach, it would be a very different situation. It would require a lot more counseling, a lot more one-on-one support from the nursing staff, from the medical team, to walk alongside the family, not to necessarily convince them, because that's not,
No.
I think, what we do, right? We don't just need
No.
to say, this is my way and your way is different, but walking alongside them, I think,
Make them
identifying,
realize.
identifying things that were important to them. So it sounded like, having their spiritual advisor there with them. And I'm sure in
Yes.
many situations, we have very strict visiting hours, right? We don't allow a lot of people to come into hospitals because we want,
Yes.
even for example, the
child.
2-year-old was allowed to visit. Those kind of things are not so normal ways of practicing, especially in a crisis setting. So I think all of those things should not be taken for granted. That the family must have begun to feel at ease, that they were, being well cared for, in the sense that this child was very sick, was very little, and the treatment, it couldn't be off. It couldn't help the child survive. Yeah.
Yes.
So
I mean, usually the families in their culture, they accept easily or not. Here, for
Right.
example, in our country, it's very difficult to make a family
Yeah.
accept.
Yeah.
There is a lot of resistance. We have to try, we have to do, even if there is a palliative team, but it's a continuous trial. You have to give all the chances. So I don't know if it's the culture that helps too.
But you could even see with the case that we had discussed, there was even within, so this was an MSF team, and they were, following the protocol from their organization. And even within that, there was differing opinions. One physician was experiencing distress themselves, right? And I think this is the reality of working in a tough situation, that we need to find ways to have good discussions with our colleagues about these things. It again may have been very difficult for that one clinician to follow through with the protocol, and he or she may not have even been able to fully express why it just really was so hard. So I think these are why it's so important that we even have debriefing sessions. We have regular team meetings, especially in these critical situations, so that we begin to find ways to support one another, so that you don't necessarily go home, or you don't continue your shift feeling all that distress, emotional distress, psychological distress on you as a caregiver, as a clinician.
And usually you do it regularly after every case, every situation.
Yeah, I mean, in this situation, especially when the team was quite having altered opinions about the protocol, I think it is really important whenever there seems to be situations like this that the team is facing. So it sounds like even in South Sudan, there's this like divide. What do? We want to provide care, but the access that we have to care is limited. We obviously don't want to see children dying. But we know from our some basic knowledge on palliative care, there's ways to provide support while a child is dying or while they're at an end of life stage. Yeah, in South Sudan, you often see the families again after the neonates die, because we were talking earlier about how palliative care is even beyond looking into grief and bereavement. Do you ever see these families, or is it really they only come when they need help, like emergency support?
I think the family really needs support, as you said it. If they bring like a palliative child, they really need of support. And according to the limit of the training, we always do the support we can do, because we have so many categories of palliatives. There are some palliative patients that may need care, that you take vital signs, you do what, you give medication. But when you come to end of life care, this is a situation where you stop everything, and no IV line, you don't disturb with RBS, you don't do everything. So you just only consider that the patients, we do only symptom control. If there are like agitation, we give midazolam. If there's pain, we give morphine. So we do only that, and they will get feeding from the family. So we don't give antibiotic, we don't give cannulation, we don't do anything in end of life care. So we do that system according to the limit of the training we have. So we do like this. But when it is like a palliative, somebody having identified to be a palliative, but we just only write the notes that don't attempt resuscitation, and we still following if it is not end of life care. So we do following, and we do all the briefing to the family. We do how do you call it, the spiritual support, so that we have church there, we do everything. Then the emotional support and all this. So we follow the guideline according to the limit we have. As I told you before, we have a palliative care team that can do that. So we have MDs and COs. We have Bang and other nurses, Galwak and me, and other MDs. So we went through training of palliatives. And we know what we know which category the patient is in. So the only question we have is in neonatal palliative care that we want to link with the guideline. Yeah, we want to know what are we going to do for the neonate who are less than 1 kg. This is the only where we have problems. Yeah, that's why we have a lot of questions. But the rest of the things in palliative care, everything is correct. Communication skills that you give us, so we understand that training and we are using it. There's no problem about communication. There's no problem about all the process of palliatives. So
we can
this is
take.
How we are doing.
I mean, we can continue to take the concerns related.
Let me have addition.
Yeah.
Let me have addition. The addition that I can add is, of course, as you heard from MD Simon, we have 2 types of palliative. There's some palliative whom are not being admitted in the facility. Like, for example, if there's some palliative whom are able to walk, they even also the symptom come in maybe after 2 to 3 days. So those patients will not be admitted in the facility because they're able to walk, but of course they are palliative, but they're able to walk, they're able to talk, they even also negotiate with their family, with their friend.
Their performance.
So we didn't keep those we didn't keep those patients in the facility. So when the symptom come in realistic like where there is a need for pain control, so that is where we can come to be admitted. Like if they are not able to wake up alone, maybe they did not able to feed themselves, or maybe they didn't able to birth themselves. So
Mhm.
whereby they need support from maybe from the parent or maybe from the nurses. That is where we come for them to be admitted, so that they need the close monitoring, like pain control system.
Mhm.
So in that situation, so we keep those patients outside as outpatient palliative care, but we are not yet, we didn't put them in the facility. So as we know that maybe in some developing countries like where you are, maybe they have the specific place where they can be admitted, but here in our area, we are
Yeah.
still in rural area where our facility is just a hospital. So we only
Yeah.
keep the patient which are critical, where there is a need of close monitoring.
Yeah.
Yeah, that is what I got.
I don't know if anyone else has any other comments to share regarding it, but I think today we've opened up a really interesting topic. And I think some of the reasons why it's so difficult to talk about these things is because sometimes it feels like this is not the way it was supposed to be. Children that are so little should have a chance at life, right? So in a way, it is almost even an ethical dilemma that we deal with personally or as a team. So I think people in South Sudan and those that are on the call today, please, if you can take something away from today, please take away the fact to not just keep it to yourself, not to keep all the weight of those decisions to yourself. Talk about it as a team. Connect with Palchase, where other providers are dealing with some of these very difficult situations. It is always difficult to take care of an adult that is palliative. It's also very difficult to take care of children that are palliative, and it is also very difficult to take care of neonates that are palliative. So I think I want to encourage you from today. It sounded like we talked a lot about protocols and, very stringent, particular numbers about, at what birth weight do we provide palliative care, and what birth weight do we do more intensive care. All of it is not easy, and it's really not easy to do by yourself. So please stay connected. I think we have some experienced clinicians that are working in the field. Dr. Megan Doherty, Dr. Catherine Richardson. I know she works with the South Sudanese team or the team in South Sudan very closely. Even Rachel, who's the one that shared the case with us, she recently did release an article talking about distress on teams when having to face these difficult decisions. And yeah, it isn't easy. So I know there's one more question here. Okay, Annalise has a question. She said, I've prepared. Annalise is working in Kenya, and they've got a lot of cholera right now. So I think she just dropped off the call. So she's quite busy. She works for IRC, which is a humanitarian agency here in Kenya. And they have a big outbreak right now where they're trying to help a lot of patients that are quite sick. Eve, do you have any comments? I see you're there. I know you've been working, or Susan, you guys have been working in palliative care a while.
I don't have any comments. I just want to thank everybody for sharing their experiences and expertise. Thank you.
Yeah. Elizabeth, do you guys deal with, I know Elizabeth is our child life specialist here in Kenya. Do you guys ever get called to the NICU or the PICU? I guess more NICU with the neonates. Do you ever get called to support families there? Maybe she can't unmute. That's okay. We have a few other people that called in. Welcome, Sylvester and Anindita. Navjot, welcome to the call. We're just finishing up. Does anyone have any final comments? We'd love for you to stay connected to our group. We have a WhatsApp for East Africa, which I know not everyone is currently based in East Africa, but we're a pretty open group. So if you'd like to join us, Oftentimes our cases will be from humanitarian settings, or particularly Uganda, Kenya, Somalia, South Sudan. And we will be offering soon another introduction course to palliative care. For some of the people that have been in the first introduction, we'd love for you, people like Bangbol and even Maria, who's been on the call for some time. If you ever have a case that you would like to present like today, we would love for you guys to bring that. I think these kinds of opportunities are good for reflection and for learning. But yeah, if we don't have any further comments, Laura, did you want to make, I know you were just listening in today, but do you have any comments for the group? Laura?
Hello. Hello.
Yes, go ahead. Yep, go ahead.
Yeah, I can say thank you, but the today presentation is very nice. So of course, if we would be having any case like the one we are facing it in South Sudan here, I think we would have to share it together with you. So as we open the issue of neonate in a palliative care, so I need you also to focus on this, like to give us the full feedback on where we can start it. So let it remain as a question. Yeah, because now it seems like we will go back to the facility. We are not yet know the limit or the age limit where we can start it. Like we know that now the kangaroo mother, the children which was born in a facility with low birth rate will be used a kangaroo mother if they have no abnormality. But for those with abnormality, so we want to know maybe is it from the birth or maybe after 1 week or maybe after 2 weeks. So that's that question. I think it can remain with you as a specialist. So I think you can give us the feedback as you have all our emails. So maybe if it, even if it is not the a session day like this, so you can just email us, Ida and Simon. So we would have to go through it. And again, also we know that we even also working with MSF protocol. We cannot just work in our mind. We went through MSF protocol. So like neonatal guideline. If there'll be any case which is defeat us, I think we can share it.
Yeah, for sure. I don't have Simon's contact, I don't think. Or Simon, are you on our group?
Yes, Simon is one of our group.
Oh, he's on the group. Okay.
Yeah, I'm in your group. I'm in your group.
Okay.
Yeah.
Okay, perfect. I just shared a link. Maybe the other thing we can also challenge one another is just to read some articles on what others are doing for neonatal palliative care. I know in humanitarian settings, of course, we have limited access of what we can access, but I would encourage you to continue to read on this area as it might be something to learn from. Okay, Laura's just saying she's having trouble unmuting anyways, but thank you so much for joining us today and hearing how the session goes. And yes, if there's anything else we can do to help you, please join our chat. I'll just put PalChase is an organization that supports palliative care providers all around the world in different humanitarian settings trying to implement palliative care. So if you ever want to get connected with us, we have regular meetings, so you're welcome to join. But thanks to everyone. So